Let's talk about suicidality and self-injurious behavior. In general, people are coming into the life, into the world to enjoy, to do meaningful, nice things. It's so pity that so many young people, they don't respect their own lives. They don't find meaning in their lives, and they don't want to live. Let's talk about the definitions. Suicide, from the Latin suicidere, to kill oneself, means the act of the person intentionally causing his or her own death. Suicidality refers to the cognitions and activities of persons seeking their own death, including thoughts, actions, or omissions. We could talk also about suicide attempt and parasuicide. Suicide attempt denotes non-fatal acts or preparations intended to result in death, while parasuicide refers to a non-habitual, potentially life-threatening self-harming behavior which is performed without the intention to kill oneself. It could be also called deliberate self-injury, deliberate self-harm, or non-suicidal self-injury. When we talk about prevalence, we should keep in mind that because of stigma, religious, cultural attitudes about suicide in many regions and countries, officially reported suicide rates are likely to underestimate the problem. And we also see country-specific patterns of risk and protective factors. For example, religious beliefs. The study has shown that Muslims have the lowest, while Christians, Buddhists, and Hindus are in the middle. Agnostics show the highest suicide rates. Also, we should keep in mind that suicidality is a dynamic rather than a static phenomenon, and we see countries where traditionally high rates have decreased, as in Hungary, and in other countries like Korea, Japan, United States, we see increase during the years. Low rates we see in Gulf states. It could be because of religious norms, low alcohol use. High rates among minority groups, those who have undergone rapid social change, acculturation, result of colonization, very sad, American Indians, Australian Aborigines, Inuits, Eskimos. As an example of nation-specific variations in suicide rates, let's see the European data. We see the mean rate of suicide among 15 to 19 years old. It was 5 per 100,000. Males, 3 times higher than females. And suicide rates, they vary widely from 1 in Greece to 20 in Lithuania. Sharp decline in Hungary during decades is obvious, because Hungary was close to Lithuania, around 20. Now we see 4 or 5. Also, we should keep in mind that these figures do not include suicide attempts, which occur 10 to 20 times more frequently than completed suicides. Let's see the suicide rates in Lithuania, because we saw that the numbers are the highest in Europe. If we take 10, 14 years old children, only 8 for boys, for girls. If we see 15, 19 years old group, same number, 4 girls remains, but 38 boys appears. It's very sad. And we have to keep in mind that target group for prevention and early intervention in Lithuania, in my country, could be 15, 16-year-old boys, adolescents. And preventative programs should be developed. Total suicide country in Lithuania is more than 1,000 people per year. It's 34 per 100,000. It's very sad statistic. I hope it will be better soon. We should keep in mind that suicidal attempts in adolescents, especially girls, not always related with depression or psychopathology. It also could be as a desperate effort to improve relationships and emotionally painful situations. And then it's important to ask, to talk, to listen, to communicate, and find complex help for these teenagers. Also, it's very important to influence media depictions of suicidal acts. As an example could be modeling suicidal behavior, the Werther effect from Goethe's popular book Sorrows of Young Werther, written in 1774, was followed by a number of suicides of young people, and it's very important how media describe suicides. We could talk also about pre-suicidal syndrome, and it compares some warning signs as a feeling of hopelessness, self-blame, or being alone and misunderstood, negative ruminations, self-pity, inactivity or social withdrawal, inhibited aggression turned toward the self as autoaggression, suicide fantasies and planning, dysphoria, also somatic symptoms, sleep problems, fatigue, and loss of appetite. And most vulnerable youngsters are lonely, having lots of free time, insecure, mistrustful, sensitive, affectionate, less intuitive in communication, as autistic spectrum disorders, impulsive as ADHD, mood, anxiety, conduct and substance use disorders, victims of bullying, cyberbullying, abuse, school difficulties, legal crisis, or also in incarceration. Here we see major risk factor for suicide among adolescents. It is previous suicide attempt and also psychopathology, especially major depressive disorder, bipolar disorder, conduct disorder, and substance use disorders. Psychiatric comorbidity, especially combination of mood disruptive and substance use disorders. Also dysfunctional personality traits, especially antisocial, borderline, histrionic or narcissistic traits, feeling of helplessness, impulsive aggression, family factors, as family history of depression or suicide, loss of appearance through death or divorce, family discord. Also, it's very sad, physical and sexual abuse or lack of support network, poor relationships with peers and feeling of being social isolated, availability of lethal means, and having been exposed to suicide. What has been seen recently, that problem sleeping in early adolescence associated with suicidality and self-harm in late adolescence. And especially vulnerable group are victims of bullying and abuse. When we talk about suicidal behavior, we could see the clinical cause and stages as a continuum, starting from suicide thoughts and ideas that sometimes are normal. If they become very intensive as a spectrum, young people start to plan, make preparations, and then they realize as self-destructive behavior, suicide attempt, or even completed suicide. So we could see consideration, ambivalence, and decision, and could see the moderate suicide risk or high suicide risk. When we talk about assessment, let's keep in mind that suicidality should be addressed directly and openly in very supportive atmosphere. There is no risk to cause suicidality by talking about. There is a risk of ignoring suicidality if the topic is avoided. Could be used structured questionnaires, rating scales, also could be helpful for screening purposes. Let's keep in mind that suicide occurs usually in a crisis, and we could see stages of the crisis: predisposition, trigger, facilitator, and opportunities. Clinical assessment by a trained professional is required to assess suicide risk. This assessment should comprise a physical and psychiatric examination, including a comprehensive history with information from patient, parents, or significant others to obtain information about acute psychosocial stressors, psychiatric diagnosis, current mental status, and circumstances of the past suicide attempts. Slide number 11. When we talk about risk assessment, let's keep in mind that often suicide risk cannot be excluded definitely, and an estimation of the level of risk is constantly needed. Special attention has to be paid to the changeability of risk and to the confidence of the assessment. Acute suicide risk is low if we see that there is no major psychiatric disorder, that patient is able to form adequate therapeutic alliance with the clinician, the suicide attempter did not intend to die, the patient clearly behaviorally states that reattempt of suicide will not take the place. The patient is hopeful about the future and has concrete goals with respect to his or her engagement in everyday activities. Stable social and family support is available and no significant life stressors are present. Then we could see that the risk is low. When we talk about management of suicidal behavior, it should be individually tailored to target the risk factors of a specific patient, and we have to make sure that the child at risk is safe and receives support. Optimal treatment requires a continuum of services, including emergency intervention. Then staff should be trained, if available, outpatient, home-based, day and inpatient treatment. Inpatient treatment units that treat suicidal patients, they should establish protocols and have plans to maximize safety of suicidal youngsters. Discharging a suicidal patient from an emergency unit or crisis center, it is always necessary counsel patient and family about the disinhibiting effects of drug or alcohol. Check that firearms or lethal medication and substances can be effectively secured or removed. Check that there is a supportive person at home. Check that a follow-up appointment has been scheduled for the patient and family. When we talk about management of suicidal behavior, in many cases, no suicide contract with the patient could be very helpful. We need to get permission, confirmation that the patient will not do nothing to his life, not in danger, not make suicidal attempt until during the short period, for example, until next day, until next session. And also we have to get commitment that the patient will actively participate in the therapy and very precise plan what he or she will do if the symptoms will deteriorate. That non-suicidal contracts help to keep person alive and it's trust from the both sides. The management of suicidality of youngsters also requires clear communication not only with him or her, but also with family and environment of the young person, especially school, and we have to get permission from the young person and family to reach the school. They could be very helpful. When we talk about management of suicidal behavior, there are many psychosocial interventions and we should use them, like psychoeducation for youth and parents, organizing support, elaboration of self-help plan with the patient, strategies to improve parent-child relationship, which very often are disturbed, also cognitive behavioral therapy or multisystemic therapy or dialectic behavioral therapy. That involves training in mindfulness, training of interpersonal skills, emotion regulation and stress tolerance. When we think about psychopharmacological treatment, let's keep in mind that there are no specific medications for suicidality. There are lots of debates about risk of suicidality with SSRI antidepressants, so we have to be careful and suicidality should be monitored during the course of treatment. When we talk about prevention, the World Health Organization Suicide Prevention Program, SUPRE, emphasizes reducing mortality, morbidity, and other consequences of suicidal behavior by three main things. First, minimizing access to means of suicide, toxic substances, firearms, etc. Second, early detection and treatment of mental disorders. And third, responsible media reporting of suicide, media guidance. Here in the scheme, we see how do suicides occur and how can they be prevented. Firstly, we see usually active disorder, stress event, plus acute mood change, and this big danger of suicidal ideation, and we have to have knowledge in society to find and treat these youngsters. And suicidal ideation could go into inhibition and survival, or facilitation and suicide attempt or completed suicide. Let's talk now about non-suicidal self-injury or self-harm. It is defined as an intentional direct injuring of body tissue, most often done without suicidal intentions. The most common forms of self-harm are skin cutting, carving, burning, scratching, scraping, picking at the wound, interfering with the wound healing, self-biting, banging, or hitting body parts, inserting objects under the skin, etc. Non-suicidal self-injury appears in emotionally unstable, impulsive patients acting out their inner distress. However, self-harming behavior may also occur in other psychiatric conditions such as psychosis, mental retardation, pervasive developmental disorders, or severe deprivation. When we talk about prevalence of self-harm and we see reviews of community-based studies, we see prevalences ranging between 10-13% till 20 or even 30%, and it is sad increasing tendency among young people. And when we see such pictures, let's see, not across the street, let's do this down the road. We don't keep in mind that they shouldn't do this at all, and remembering that each fifth or each third young person self-harm somehow, we should do everything to diminish this. Risk factors of non-suicidal self-injury comprises high psychiatric morbidity, especially mood disorders, substance use disorders, externalizing disorders, other risk factors associated with a history of sexual or physical abuse, negative, stressful life events. And now there is concept of multi-impulsive syndrome described. It means that there are subgroup of young people and adults who have problems in impulse control. And it is related with eating disorders, binge eating, suicide attempts, self-injury, stealing, severe alcohol abuse, promiscuity, or severe drug abuse. And it is problem to control their impulsivity. Here we see the table that summarizes the different psychological functions that may be fulfilled by self-harm. A framework to analyze self-harming behavior is provided by operant learning theory, and functions could be different and different aspects of them. For example, affect regulation, anti-dissociation, to end feelings of dissociative states, anti-suicide, to replace compromise or avoid suicide attempts, or for example self-punishment or sensation seeking, or seek help or manipulate other people around. Here in the table we see analysis of the consequences of non-suicidal self-injury, and we should keep in mind, according learning theory, that positive and negative reinforcement aspects meets both intrapersonal and interpersonal or social functions that also it's very important to understand and to use in therapy. Assessment of non-suicidal self-injury should take into account methods and frequency of current and past self-harm, suicidal intent, depressive symptoms, psychiatric illness, personal and social context, specific risk factors and protective factors, coping strategies, significant relationship that may either be supportive or represent a threat as abuse or neglect, or long-term risks, And not only the patient, but also parents, caregivers should be included in the assessment. Individual psychological and somatic investigations of the self-harming patient is also very important. Treatment of self-harm have same principles as suicide attempts. Patients severely harming themselves may need the same close supervision as patients with high or moderate suicide risk. Risk management plan should be developed covering strategies to deal with the risk identified: psychological, pharmacological, social, or relational. This plan should include self-management strategies and ways of assessing services and receiving support during a crisis when self-management strategies fail. Self-harm treatment successful when we find therapeutical and social resources in the environment of the patient. Also, we should keep in mind that balanced day structure and body health are very important issues. For example, sleep, fresh air, balanced nutrition and minerals in the body as ferrum, zinc, magnesium, vitamin D levels. Fish oil as IQ formula could also be very beneficial. Each young person should have physical activity, exercise enough, computer time and content, TV time and content also is very important. And if young person have good post-school activities, have possibilities to express herself or himself in art, in sport, their mental state, emotional state will be much better. And also it's very beneficial forms like relaxation, breathing techniques, meditation could be used. In treatment of self-harming youngsters, it's very important to teach them effective self-regulatory strategies because they have problems in impulse regulation. Also teaching relevant emotional expression and constructive communications with the environment. Feeling of social belonging and importance is needed. Psychosocial interventions, individual and interpersonal psychotherapy and medications as antidepressants or mood stabilizers could be used. Various forms of art and body therapies, if possible, help in finding of the individual answers to existential questions for the young people are essential. Meaning of life and spiritual coherence, harmoniousness with the environment. Finding these things could be way or pathway to good mental health of young people. What could we say as a summary? Suicide attempts, self-harming behavior are extremely dangerous and increasing in youngsters. Suicidality is a dynamic rather than static phenomenon. It is important to take into account country-specific patterns of risk and protective factors, stigma, religious beliefs, access to lethal means, use of alcohol and drugs, identify most vulnerable groups. Complex help is needed comprising individual, family, environmental assessment and coverage of the target risk factors for every specific patient. It is important to understand suicidal risk as a continuum, suicidal thoughts, intensity of the ideas, plans for suicide, preparation, suicide attempts, and to establish a relevant plan of the crisis management. Prevention and especially relevant media reports are very important to avoid relapses and increase of suicidality in the society. I wish all countries, all young people and all professionals to be strong, healthy and enjoy life.